Hi, it's Dr. Distano. I want to talk with you about pain. The research shows if we have a current evidence-based understanding a little bit about the neuroscience of pain, that can actually have an impact positively on your levels of pain because when you understand your body and when you understand what's going on, it becomes a little less threatening. So pain is a natural part of life, and it is essential actually, even though it can be uncomfortable at times. But it's our body's alarm system, and it's designed solely for protection and motivation. If we didn't have pain, we wouldn't know something is wrong, and we wouldn't be motivated to take action to correct the issue. So it's our body's alarm system, just like we have warning signs on the dashboard of a car. When our brain or our body detects that something is wrong, the pain alarm is triggered and we take action. Just like on our dashboard, if the tires are low in pressure, we go get air on the tires. Now, despite what most people think or what seems like common sense, pain is actually produced by the brain. It is not produced by the body, even though we feel the pain in body parts. When we are in pain, we know that areas in the brain associated with that body part light up. And that's not really a shock because we know that the brain is responsible for processing all of our senses and emotions. For example, when we're seeing objects, it's our brain that's determining what those objects mean and past experiences and emotions related to those objects. Our eyes transmit light waves, but the brain determines what sense to make out of those light waves and the context around it. And pain, since it is produced by the brain and not the body, is heavily influenced by our thoughts, beliefs, past experience, behaviors, emotions, and lifestyles. So it's not just what's going on with the body that influences pain, it's us as a whole. And that's essential to understand about pain and what influences pain to understand how our treatments could actually help somebody in pain. Because we don't need to change someone's x-ray or MRI findings to influence pain in a positive way. And to give an example of that, we know that with pain medication, someone can feel better, or with an injection, someone could feel better, or even massage. And that's not because anything was changed on the x-ray or MRI. The only thing that was changed is the way the brain is processing and producing pain levels. So that's very reassuring that we don't have to change any anatomy or structure or put anything back in place to help someone with pain. In most cases of musculoskeletal pain, that is pain associated with muscles, joints, ligaments, etc., have a favorable prognosis. Less than 10% of patients become chronic and have ongoing pain. And even though most of the time the prognosis or the outcome is favorable, the reoccurrence rate for example, back pain or neck pain is high. But there are strategies that we can educate our patients about to help reduce risk of recurrence, or if you do have a recurrence or an exacerbation of past pain, that you'll better be able to manage it and reduce the amount of time that you are in pain with our self-help strategies. Another important concept to understand as far as pain goes that hurt does not always equal harm. And we can be safe but sore with movement and activity. Now, what that means is many cases, pain is not associated with any injury or trauma, particularly if the pain has been ongoing for months or years. If there's been no trauma or injury to the tissue, chances are that the pain you're feeling is that your nervous system and your brain is on high alert and it's producing pain to protect you even though there's no injury. When that happens, a lot of movements that normally weren't painful are now painful. Or activities that you may have been able to engage in for 20, 30 minutes or an hour without feeling any pain or discomfort become painful immediately. For example, you may have been able to sit or stand for 2 hours without pain. Now, over time, the last months or years, you can't sit or stand for 5 minutes without pain. So that doesn't mean that you're in pain, you're damaging anything. It's just that your brain is becoming overly efficient at trying to protect you. It doesn't mean anything's injured. And that's important to understand because with our treatments And with exercises and stretches, if you've been in pain for a while and your pain processing system is on guard, you will feel pain with certain movements, but you have to understand that that pain does not mean you're harming anything. It's actually a healing type pain that we're trying to have your body and nervous system adapt and turn down that sensitivity or calibration of your pain levels. So hurt does not equal harm. We can be sore but safe with movement and exercise. And as I just said, pain without injury is not associated with damage. If we wake up with pain or we're not really sure what caused the pain, it's important to examine, again, as we said, what we know influences pain, and that is our thoughts, emotions, stress levels, activity levels, sleep levels. So if you've been dealing with pain and you're not sure why or what triggered it, we can't only look at the position or posture that you're in. Yes, that is important, but let's look at how's your stress levels been? How has your sleep been? How has your diet been? Were you active and then you became inactive? So we have to take a view of the patient as a whole to determine what triggered the painful episode, particularly, like I said, if there's been no injury or trauma, there may be more that we have to dig a little further to fully help the patient. So our thoughts, emotions, cognitions, and lifestyle can be adding fuel to the fire. So something that may have not felt very painful in the presence of these factors that are up on the screen can make episodes of pain feel worse. Or if we're not in pain, but we've been under a lot of stress and not sleeping well, for example, and maybe not eating as we should, what normally wouldn't even trigger a pain response and get to our conscious level is now painful. And the more we worry about it, the more the stress progresses, or the more improper sleeping habits progress, the more pain we feel. And again, what triggered a pain response is now having fuel added to the fire by our thoughts, emotions, and beliefs. So the way we think about pain, the way we view pain, having friends or family that had bad experiences with pain or are in chronic pain or past surgeries, they all influence our level of pain. And the fact is, most of the time we want to know what exact structure is causing the pain. Is it a disc? Is it a rotator cuff tear, for example? And what the research shows, unfortunately, is most of the time we cannot identify one exact structure causing the pain, because in musculoskeletal pain, many times there's multiple structures contributing to the pain. Now, very rarely we could clearly point to it's a disc, herniation, impinging a nerve, for example, or yes, it is definitely the rotator cuff or tendon that's contributing to your pain. But most of the time, what the research shows is we cannot do that clinically. And the good news is we don't have to identify an exact structure in order to treat you efficiently and for your pain to go away. Because again, we're not trying to change structure. If we had ruled out serious causes of your pain, such as tumors, infections, or fractures, and we categorize your pain appropriately, be it mechanical, which is pain made better or worse with certain movements or positions, chemical, which is pain related to injury or trauma where there's inflammation, or neurological, where there's shooting pain, such as sciatica, associated with numbness, tingling, or weakness. Once we categorize it, we could efficiently treat you. We don't have to know exactly what structure is causing the pain. Another point that's very important to understand, because most patients want to know, do I need an X-ray or MRI associated with the pain that I'm in? X-ray and MRI really have to be used judiciously, because there are many false positives that will show up on an X-ray or MRI that the research shows may not necessarily be contributing to or causing your pain. For example, we now know that many findings on an X-ray or MRI are associated with normal age-related changes. If you're over the age of 30, you will have some degree of disc degeneration, or the beginning stages of arthritis, or maybe even some disc bulges or fraying in the rotator cuff. Those are normal age-related changes, just as our skin changes as we get older. And what the research shows is those rarely are correlated to pain. But what is highly correlated to pain more than our X-ray or MRI findings are our pain-related thoughts, emotions, and cognitions. And that may be hard to understand, but if you understand the way the brain works in pain, we can easily see why those things mean more and have more of an influence than an X-ray or MRI. To further drive home that point, I explain to patients how you may have arthritis in your finger and not even know it. We may take an X-ray and it'll show the arthritis, but you're not in pain. Now, if I bend your finger all the way backwards, eventually you will be in pain. If we hold it there all day, you'll be very stiff and painful. Now, if you get the X-ray, you may think, oh, the arthritis in my finger is causing my pain, but really it's not. It's having your finger bent backwards for hours on end that's contributing to the pain. And when you do things to make your finger stronger and learn how to stop bending your finger backwards, so in a sense, posture management of your finger and making your finger stronger and exercising more, the pain in your finger goes away. Now, the arthritis is still there, but your finger's now strong and you know how to not irritate the finger. So that's just an example how we can't only rely on X-ray or MRI, even though they do play a role and they are important. They're a small percentage of managing patients. And again, they don't have to have any X-ray or MRI findings changed in order to get out of pain. Really, what we use X-ray or MRI for is if there may be a change in management, if we suspect something serious like cancer, infection, fracture, or if we think the pain may be referred from organs presenting as spine pain, or if surgery or an injection may be an option and we have to try to localize at what level do we operate on or what areas do we inject. But that's less than 10% of the time that we need those imaging findings. And they really, for the most part, with what we do, they don't direct or dictate care. Patient goals, patient signs, patient symptoms is what directs care. And it's important to understand that movement is definitely medicine. The research is clear about this. Movement and exercise is the closest thing that we have to a miracle cure for not only illness and disease, but also for pain management. So, as I said, you have to understand these pain principles to understand why it may be safe and necessary to move, exercise in pain, and why some of our treatments may gently provoke pain in a controlled manner.